Pete, so glad to have you here. You're a busy guy. Um, you are at the Institute for Healthcare Improvement today as a speaker in Orlando. So thank you so much for breaking loose uh, and talking to us. So I met Pete at a YPL meeting at Tampa General Hospital. I don't know, a year ago or so. Pete, and I was so impressed because he really stole the show there about some of the things that he's doing to help them reinvent a hospital. So, Pete, I'm going to maybe try to pull some of you into this conversation about who you are, how you got there, what you're doing, etc. So, Pete, first of all, you're an IHI. What are you doing there anyway?
Sure. So I'm not sure if all of you are familiar, but IHI is a large not-for-profit institution in the world. They're an international company that focuses on quality and sustainability inside of healthcare. And I'm not sure if you're familiar with Don Berwick, who really led a lot of the quality movement in the United States and now international, but he was the former head of IHI. And so they have their national forum in Orlando every year. And I'm here giving a talk on, actually completed a talk on AI and healthcare. Is it real? And what the status of AI and healthcare really is, Jim.
All right. Well, very impressive. And yeah, we know who Don Berwick is. In fact, some of the people here are personal friends of his. So we talk about him and the triple aim, the quadruple aim a lot here. So I'm glad you mentioned that name. Well, uh, Pete, you started out as a academic hospitalist. You're an internist, and how did you become, I guess, pretty soon after that, a chief transformation officer? We have a lot of hospital CEOs here. We have on the screen. We have a lot of physician executives, and tell us about your journey. Well, we're going to get into some of the stuff you're doing at Tampa General Hospital, but this is kind of a leadership class too. And tell us about how you transitioned up through Tacoma General Hospital.
Yeah, so it's actually a really interesting story. So I've been at Tampa General. Next year, 2024, would be my 20th year at TGH. I began my career as a medical student at the University of South Florida, and our biggest affiliation for a teaching hospital was TGH. And so kind of came up through the ranks, went on to do my residency in internal medicine at TGH. And then I remember pretty profoundly, I was a resident on a Tuesday, and on a Wednesday, I was an academic attending, transitioning from my third year of residency to being a first year attending with a group of medical students and residents following around with me on rounds at the hospital. So it was a big transition, probably one of the big career steps in my life, and was enjoying my time as an academic hospitalist. Was probably on the track to become the program director of our residency program. So we're a pretty large residency program, probably around 120 internal medicine residents, and loved every minute of it. Really have a passion for teaching. And at the same time, the Epic implementation was going live at TGH. So I was involved on the periphery of creating order sets and templates for our hospitalist group and our residents. And during that process, one of my colleagues gave me the old elbow and said, "Hey, Pete, this chief medical informatics officer position at Tampa General is open, and you would be perfect for it." At the time, I didn't even know what CMIO stood for. And but lucky enough, I did know who the chief information officer was at TGH, and gave him a call and said, "Hey, yeah, sure, Pete, let's go out to lunch and let's talk about it." and kind of married the issues I knew that were going on at TGH with the technological gaps that I saw and what I would do about it. And sat down at lunch, and the next thing you know, I was thrusted into a 2-day interview process for the CMIO role at TGH. No formalized MBA, leadership training, or informatics background, just a doc that was passionate about IT and healthcare. And lo and behold, they ended up giving me the job a week or two later after the interview. So then I kind of looked in the mirror and I said, and now what? My training program, Jim, for my interview process was YouTube and journal articles on CMIOs in the industry and figuring out, what they were doing, kind of how the field came about. And from then it was off to the races. And that was probably the second biggest learning curve I had in my career, was transitioning from a bedside physician to a hospital administrator, as funny as that sounds. And went through that process and did lots of really amazing projects at TGH and the University of South Florida. Really fell in love with analytics and clinical workflows, and most importantly, making things easier for both providers and the patients.
Mhm.
Did that? Sorry, Jim, you had a question?
Well, yeah, I'd like to drill into this a little bit more because of the audience we've got here. Uh, Pete, any advice for our physician executives that may wonder about going from a clinician to a physician executive, or to the hospital CEOs who may or may not have a Pete Chang somewhere on their medical staff, but any advice as to how to do this? Because it sounds like you're saying you're pretty much self-trained, or how did they recognize you? It seems like it's worked out. You and somebody else has done something right here. What did you do right?
You have to find the culture for innovation. And John Corus, who's our CEO, really embraces innovation from the ground level all the way to the C-suite. And it's funny, at IHI we were talking about we meet so many different folks from different organizations, and more and more the folks that are at our organization that are going to conferences like this text me all the time and say, I'm so happy that I work at an organization that supports my passion. And so, Jim, to find and cultivate those individuals, it's very easy. There are thousands of people just like me embedded in organizations across the country. It's how do you find them? How do you provide the avenues to engage with them and see where their passions and talents lie, and how that could actually help a health system? And so for me, the why is very simple, Jim. I became a physician, as generic as it sounds, to help people. I could have been a police officer or a teacher and help people, but I think my love of science and medicine and the connection you have with patients as a physician or a caregiver is so unique, much different than other fields. And that's really why I chose medicine. Now, the opportunity that we have in front of us is I can help one patient at a time at the bedside, or potentially I can help hundreds, thousands, or tens of thousands of patients with the things I'm able to do inside of our health system. And that's really what keeps me going every day and waking up excited to come to work.
Yeah. Well, and John Chorus is phenomenal in with the innovations that you folks are doing there at TGH. And uh, Pete, tell a story about how you became the the design guy, or how that became part of your title. Because John, the CEO of TGH, uh, goes to things outside the industry for ideas. Like he got that idea at South by Southwest, right?
Exactly. So, Jim, if you look, I won't go into heavy detail. I think starting off the career was an important story to tell. May 2024 will be my 10th year as a hospital administrator at TGH. And I've reported to 6 different executives, including John, in 6 different
Mm,
positions in that 10-year period. And I think it just goes to show you, healthcare it's not a static environment. It's a changing environment, especially with the advent of technology and the work that we're doing now. And I think John champions that, and he recognizes it, which provides me a great avenue and opportunities to do the work that I really love. And without his support and the support of the other executives at TGH, being innovative wouldn't be as easy as it is at TGH. We have a tendency. There's a T-shirt I want to make that is healthcare's mantra. We've always done it that way, with a big circle and a line through it, because that can't be the way we continue to do it. The perfect example is all of the great work that we did inside of the command center. That was kind of my second big move after informatics and IT, was creating our command center. And I see my career as evolution as I learn more about healthcare. And although we did amazing work inside of the command center, the purpose of it was essentially to make an inefficient system more efficient.
Mhm.
And during that process, I realized, well, that's good and it's valuable work and it helps patients and it helps the hospital. But ultimately, we need to figure out a way to do something really disruptive and redesign the system the way it should be for patients and providers. And that's kind of the journey I'm on now.
Mhm. Well, I'm wondering with the doctors here uh, on our Lyceum, are medical staffs more stable than CEOs? You worked for a bunch of them. You're still there. So there's something going on that may be empowering to physicians that want to make a difference, because maybe you're going to outlive the CEOs that are turning over so fast right now.
Jim, as I started off, I've been at Tampa General for half of my life,
Mhm.
which is a pretty amazing statement. And my biggest joy, besides the work that I do every day, is identifying additional physicians that are passionate about the cause and have the skills and the talents to take it where it needs to be, because I'm only one person. And healthcare is a team sport. And it's not only physicians, but it's our nurses, it's our ancillary staff, our operational folks, finance, everyone within the organization, and finding these sort of crystals of innovation to grow them and cultivate them is really the goal. And so you really have to provide that environment, Jim. And it's not something that's easy to do, but you have to find a way to engage with the folks that are interested in this type of work.
Mhm. Pete, let's talk some about PGH's innovations. That culture that seems to be there. Um, Over your signature block, you've got a an aphorism of "We heal, we teach, we innovate." So innovate is one of the three things that makes it into that tagline. And so, what's your interpretation of what innovation in healthcare means?
It's very simple. I mentioned it a little bit earlier. It's challenging the status quo. It's doing things differently than we've done them in the past. And that's a difficult thing to do when everything is working. Like nothing, it's not broken, because if it was broken, people wouldn't be able to access care and our hospitals would crumble. It's working, but is it working as good as it could? And reinventing something that is working fine is really the goal. We know the things that are broken inside of our health systems, and those are being actively worked on as we speak. But it's sort of asking the question, when you wake up in the morning, do you kind of do the same thing every day? And what happens if that changes? And it really kind of opens the door to, I think, the key component of innovation inside of a health system is your change management strategy. Because no matter what we do, if we create the best system, if we don't have a good change management strategy for our team, a good culture within our organization, and most importantly, a good change management strategy on how we're engaging with our patients, then we really have done nothing despite designing a great system.
Yeah. Well, so uh, in healthcare, we certainly get criticized for being behind the rest of other segments in innovation. Why is that? Why is it so hard to innovate in healthcare?
It's really hard for the reasons I spoke about before. But I think the difference, which if you look at all industries, right, you guys will probably laugh when I tell you which industries, at least I tend to think, are behind the times in the way of innovation. It's healthcare and education. And if you look at the main reason of why, it's because we're not building a Toyota or assembling a cell phone in a plant, or manufacturing something. We're talking about people, and that's the common denominator in both healthcare and education. And so our goal at Tampa General is to find a way to reach mass scale personalization in an economic fashion. We know it's always a mixture of people, process, and the last mile is technology. And that's really kind of where that innovative spirit comes in. We look at innovation as how we're teaching and training our people. And I've actually got John saying now our people are number one. People are always number one. And unfortunately, I hate to say it, patients aren't number one. Because if patients were number one, everyone's been saying patients are number one for years. And if that's the case, would healthcare be better if that was our focus? Our focus is our team, because ultimately, again, our team is not a machine. Our team are the people that are treating and taking care of people. And that's really the variable. It's the same in education. Your teachers are your number one team because they are the ones that are educating our students. And it's the same type of concept. Second to that is the process. I think it's on the same playing field as people because you have to have the right skills within your people, but then you also have to have the correct processes for them to feel fulfilled in the work that they do every day. There's nothing like a bad process to make somebody really upset and not like their job. So we need to find out what those broken processes are from the team themselves. I can't sit in a tower and decide that's the way this process should work because I don't have to do it every day. And then the last mile, Jim, is really kind of the most important piece, but the last to consider, which is really the technology. You can put great technology over poorly trained people and a bad process, and it will fail every single time. The technology component of innovation is really integrating it into both the people and the process and the workflow. But that's kind of how we view innovation and how it should be. And there's so many parallels to education, although it's a different field. And ultimately, there's so many principles of education that apply to healthcare because as a healthcare provider organization, we are teachers to our patients, right? They learn from us and we learn a lot from them likewise.
Hmm. Well, let's talk about some of the specifics that you're doing there at TGH. So, Pete, you and I had a wonderful conversation in the lobby over there where you had converted it into a home uh, to make push the idea of how much could you do using wearables and technology to push care out of the home. And I was intrigued by that discussion is, well, how far is this going to go at TGH? And you said, well, if John had his way, we would go from over 1,000 beds to 100 beds. So uh, that's not going to happen. But you're making some changes there. You have a fleet of cars with TGH at home on them, and so tell us about. I know you're not calling it hospital at home because I think you think that's too narrow because there's lots of things that could be done at home. So I hear you talking about at home care. So what have you done there?
It's a great question, Jim. We really see the frontier of how care is going to shift, at least in the United States, to moving towards the home, meeting patients where they are. And instead of, again, having patients react to our scheduling and our terms, we should start to be a little bit more flexible and meet patients where they are, where they are and accept their terms. Because that's going to lead to better adherence to treatment protocols, et cetera. And so I'm not sure how many of you know, but we applied for the CMS hospital at home waiver, the acute care at home waiver, probably around 2 years ago now. And were granted the waiver relatively quickly in the matter of weeks and started our hospital at home journey, which that's really disruptive. That's taking a hospital-based care system and essentially bringing the hospital to the patients, not ambulatory, not observation care. And we were able to do this because the CMS actually supported the full reimbursement as part of the public health emergency. And that expired earlier in May this year, and then fortunately got extended through 2024. So we have another year and 3 weeks for a run at really trying to support hospital at home and grow the program. And it's financially feasible for us because the average reimbursement for these types of inpatient admissions are about $7,000 to $9,000 per patient. So we're able to sort of fund the program and at least make it economically feasible to start a program like this. That's the other component. And we could try to be innovative as we want, but if we can't find a way to pay for it, it's tough. And so we take the hospital to the home. And as Jim mentioned, we named the program TGH at home versus straight up hospital at home because we see the continuum of care going well beyond hospital. We don't think that we're going to do ICU at home for obvious reasons, sort of really too resource intense, both from a labor and equipment perspective, but down the acuity scale to expand to observation, looking at innovative programs like urgent care at home, being able to operate care coordination triage lines so patients can call into those, report a problem. I can triage, dispatch a person that goes to their home, does laboratory and basic imaging diagnostics with ultrasound, makes a diagnosis, and then we decide at that point if a patient needs to be admitted or not. If they meet inpatient criteria, have them be admitted to the program without ever leaving the walls of their home. That's really the goal of trying to do this. And it goes back to the technology equation about scalability and how we're operating from an efficiency standpoint. Perfect example, Jim. Do I want my highly skilled nurse driving medications and laboratories back and forth between a patient's home and the hospital? No, I want them spending the valuable time with patients and can create a courier system to help offset some of those types of logistical challenges. We also see the continuum extending into subacute rehab and potentially skilled nursing type programs at home, different modifications of assisted living at home, in addition to infusion at home. And you can just go on and on all the way down to primary care at home. So we're currently, operating a hospital at home program, but working to build out that entire spectrum for continuous health within the walls of a home.
I see a lot of you chomping at the bit to enter into this conversation, and we're going to be doing that in at the top of the hour. I do want to get a lot of Pete's brain picked here in the meantime, but he's agreed to stay around for an additional half hour, and we'll just open this up, and everybody can raise their hand and be part of this conversation. So please do. Pete, I do want to have you talk about your care your care coordination, the idea of getting the right patient to the right care at the right time. I hear you talk about how do you do that? And one of the ahas I had was when Pete showed us around his NASA looking space center. And I took a picture of it, and that was on the announcement that you saw at the bottom. So you may have got a little bit of a visual for that. It's stunning. And how did that happen? Your experience center. Tell us about that brainstorm you had.
So it was a really interesting transition. And as I mentioned, 6 different positions in the last 10 years at TGH. Each of them has been a building block for the one that's previous. And so, moving from informatics, identifying operational issues from an informatics perspective, and then moving into operations to create the command center was a dream. And I remember the first time I met John Corus, I had my 15-minute intro to the new CEO. And I had the idea of a hospital command center ruminating in my brain for 2 or 3 years prior to John's arrival. Sat down with John, shook his hand, and said, "Hi, my name is Pete, and I want to build a command center at Tampa General." That was my introduction to John. And he said, "I already know who you are, and I'm making an appointment with a couple of vendors, and we're doing this, and you're going to lead it." That was his opening statement to me. So hopefully that sets the stage for the sense of innovation of what we have here at TGH. And from then it was off to the races. We built an 8,000 square foot, 40 screen, 30 plus team member command center that operates everything from access and throughput on the front end, which is really trying to reduce length of stay to the appropriate amount of time. Then the next one was moving on to quality and safety, which as a doc is most important to me. So implementing protocols with technology, people, and process to detect sepsis earlier. With that advent of the new process and technology, we've been able to decrease 48-hour mortality. So from the time sepsis is called to 48 hours by 54% in a 6-month period. That equates to over 300 lives saved a year, Jim. So just amazing work from a quality, and that's actually what I was presenting this morning at IHI. It's such an amazing opportunity to make a difference in the lives of our patients and our team. And then the third component was really taking access, throughput, quality, and safety, ramming it together and taking it outside of the walls of the hospital. And so the work that I did in the command center, again, I kind of alluded to it earlier, I got to the point where there wasn't a ton of efficiency left to squeeze out of the system. The system needed to be redesigned. And I started to look at where we had the biggest issues of patients coming through our system, right? We know that, again, the way of the world for a hospital to operate on razor thin margins, despite being a multi-billion-dollar organization as TGH is, I would never expect our margins to be as thin as they are. But the reality and truth of the situation is every year we get paid less from payers, despite inflation on the labor and supply side. So we need to continue to innovate and diversify the services that we provide. And a lot of those are going to be in the specialty procedure and surgical realm. So the next question is, if I have a ton of medical patients coming through my ED because they can't get access in the ambulatory setting, then I can't make space to operate and do these really high acuity, very specialized procedures at my hospital. And the way of the world is to try to figure out how do we take care of every single patient that walks through our door. And Jimmy mentioned earlier, we heal, we teach, we innovate. And the last tagline of our statement is care for everyone every day. And it is the core mission of our hospital, and we have to find new and innovative ways to do it. We talked a little bit about home, but that kind of points to the second thing you mentioned, Jim, that I've had the opportunity to lead at the hospital, which is the concept of an experience center. So taking our access center, patient access center, and changing it into the concept of how do we navigate care for a patient? How do we get them the care in the right time on their terms, whether it's in their home via a video visit? How do we digitize some of those solutions, understanding that not every patient's going to follow that digital pathway? Right now, 90% of our patients pick up a cell phone to access our health system. And we need to find a way to gently nudge them in the direction of digital front door and engaging that with them as every other industry does. So surprised that both of my parents and their adoption of smartphones and their ability to sort of learn on the fly and do things that I never could have imagined 10 years ago they would be doing from a mobile device. I think we can get all patients or most of our patients there, and then always have that front-facing person that if someone decides not to navigate via technology, that we also have that option for patients too. But it's really been an interesting journey to transition between these things, and hopefully what we see is decrease ED utilization on certain subsets of population that we have focused programs around to make sure we're monitoring them at home, making sure they're getting appropriate access and catching a deterioration before they show up in our emergency room. That's really the long play for us, and that's the redesigning the system part, Jim. That's really tough, but much needed work.
I hear you guys talking about partnerships as an accelerator of your innovation. Can you talk about that? And Kane, I see on the screen here, one of your partners is Shields at Home. So, how do you? What's your attitude towards partners? How do you do that?
Well, like I said earlier, Jim, healthcare is a team sport. And as a healthcare system, we can't do everything by ourselves. We need some of the speed and adaptability from private industry to help us. There's a lot of private equity investment in physician groups and technologies these days. There's the venture capital side of things too. John frequently mentions that it's going to be not one or the other that's able to help healthcare improve. It's going to be a combination. It's figuring out that right combination. So we were lucky enough to find Shields at Home as a partner with TGH, and what we're trying to do is just share the knowledge of hospital at home. And spread the concept of hospital home that's been so successful at TGH to other organizations that have similar issues, and create a consortium of hospital at home users that we can pull off of, innovate on together. It's getting everyone's ideas organized and pooled, and figuring out how do we approach something that makes the system more efficient, to pool resources for issues like potentially monitoring patients during off hours and weekends, versus every single organization standing up their own infrastructure to do that. And that's really part of the collaborative that I'm building with Kane and his team, and Jack Shields with Shields at Home. And for those of you that don't know Jack is a serial healthcare entrepreneur that has had multiple ventures. The most recent being the Shields Specialty Pharmacy Group that's been widely successful.
Yeah. So before I open this up to more of a group discussion, Pete, tell us about your attitude about AI. Um, what are you doing? How's that changing your trajectory? What are some of your concerns about AI in healthcare?
I don't really have a ton of concerns at this point in time, the way I understand how AI is going to operate. Interesting to see the White House's press release in October on figuring out how we govern AI. I think if you haven't read it, just Google White House and AI. It's a good read. And it's good that we're talking about it. My concern is probably over-regulation of AI, because the regulation should be AI should not make a diagnosis. AI should never be the final decision maker in the outcome of a patient. What we need AI to do is help aggregate and present information to the people that have to make the clinical decisions. And I think that's really the important role. There's that component of it, which is a little bit more care related. And then the other component is automating the administrivia inside of healthcare, prior authorizations, back-end financial workflows, all of those things that make it really difficult to get care because of the way the payment system works in the United States. You look at companies like Olive, who had multi-billion-dollar valuations, a ton of investment, and now maybe aren't doing as well. And why is that? They focused in on the financial space, but they went pretty wide and pretty fast and figured out this is really hard. Despite something being binary like a prior authorization, there's so many different facets to it that I think that's really the challenge. And again, it's not a technology play. You got to hit all three components of that three-legged stool: the people, process, and technology. So I don't really have a ton of concerns. We're putting together our own AI governance group led by our current Chief Medical Informatics Officer, Dr. Patel at TGH. And I'm, of course, a part of that group. And the goal is really to set up a governance group that looks at utilization, ethics, current technology, impact to the organization, um, things like resource utilization, both from a cost and a team member perspective, to see, are we really ready to implement this widget? And then setting up those subgroups underneath that are arranged by service line, because despite this larger governance group having some really great experts on it, we're always going to have a deficit, because if we don't have a neonatologist on that group, and there's an AI neonatology app then how do we vet that through a system? It's got to come from the service line. It's got to follow a specific format and then come up to the larger governance board and tell us why this is important for that patient population, and then make a joint decision on what we're doing moving forward. But strategy is key as you start to look at AI and how it's implemented within an organization.